Varicose veins. You may be wondering, why do I have these varicose veins and what can I do about it? I'm Dr. Paul Zalzo.
I'm Dr. Brad Wing. Welcome to Talking with Docs. We're going to help you learn about it, figure out why you got it, what you can do. We brought a special guest in all the way below the 49th parallel. Dr. John Chuback is with us, cardiovascular surgeon. Welcome, John.
Thanks for having me.
All right, you're going to teach us today. This is Talking with Docs. If you're new to the channel, it's just a couple of docs or three docs talking, okay? I guarantee you'll learn something by the end of watching one of our videos, and I guarantee you that we will have fun making this video. Hopefully you enjoy watching it. Dr. Chuback is going to teach us now about varicose veins.
Okay, let's start at the beginning. What's a vein and why do we get varicose veins?
Well, veins are a very important part of the circulation, part of the cardiovascular system. Generally, there are caveats here, I won't go into them, but generally veins bring blood back to the heart, deoxygenated blood back to the heart. And that's very important because arteries are pumping blood with oxygen and nutrients into the soft tissues to keep them alive, but there has to be flow back to the heart, and that's why we call it a circulation. It's kind of like a circle. Blood goes in, blood comes out. And for those veins to function normally is almost a little bit mysterious. I mean, we do understand the physiology of how it works, but when we're sitting, let's say, for example, in these chairs with our feet in what we call a dependent position, the question is, how does that blood get back up to my heart? I mean, it's pretty obvious how the blood gets into my feet. I have a, muscular pump in my chest about the size of my fist under high pressure, pumping blood downstream with gravity into my feet. Right. But what brings it back? Well, one of the main mechanisms is walking, as you guys all know, as orthopedic surgeons, one of the greatest ways of bringing blood back, what we call the calf muscle pump, and those act like little hearts in our legs. But when we're sitting like this, then what's bringing it back? The only thing really bringing it back now is breathing, our ventilation. When we expand our chest, we create sort of a bellows effect, a negative pressure in the chest that creates a vacuum and literally sucks the blood back up into the heart. And that blue blood then needs to go through the heart, back out to the lungs to pick up more oxygen to go back and keep us alive.
Okay. I am so painfully aware right now of the blood in my legs. I'm doing everything I can not to get up and walk around.
That's
now.
why you should wear stockings.
Compression stockings.
Yes, compression
I should
stockings.
have. I'm just going to keep tapping my feet to pump it up.
Okay, so now we know what a vein is.
The way I remember it, the easy way, is arteries carry blood away from the heart because they both start with A. Then veins got to bring it back.
Okay. I like it. So now we know what a normal vein is. So and the main difference between an artery and a vein, John, you'd say, is that the thickness of the muscle around an artery is a lot thicker. The ability for it to contract is very different, and the amount of pressure in an artery is higher than a vein. The other thing that's really important, I think you're going to mention it when we talk about varicose veins, is the presence of one-way valves. Can you tell us a little bit about why that matters?
Yeah, well, it's very important. Arteries do not have valves. Veins do have valves, and they're two little leaflets that open and close. And it's like a one-way check valve. So it opens up toward your heart and the blood can go up, and then that check valve closes nice and tight so the blood can't go down. But the main problem behind varicose veins is something we call venous insufficiency, meaning that those valves aren't working properly in the veins. They're insufficient. So one of two things can happen. They can just flop back and forth like a set of old saloon doors in the old Western movies, or through chronic inflammation, those little valves, which are extremely delicate, like butterfly wings, they get gobbled up. And I always say, inflammation, it's the root of so much disease. If it can eat through a knee joint and the cartilage and bone and all of that, think about a butterfly wing. It's no match.
Doesn't stand a chance.
No match for inflammation. So inflammation is the source of chronic venous insufficiency. And we know that a lot of that is inherited, and some of it is from standing and sitting upright and the pressure that we put on the system. But once those valves get destroyed or become dysfunctional, now with gravity, blood is constantly being pulled back down into the leg, away from the heart, pooling in the leg, and that leads to swelling, pressure, and skin changes and all kinds of things like that.
So I think this is an important distinction. So let's talk about the difference between a varicose vein and chronic venous insufficiency and whether they're obligatorily connected. Can you have just a varicose vein and not have venous insufficiency and vice versa?
Yeah, I think this is the subject of mutually exclusive, right? Correct. If you have varicose veins, by definition, you have venous insufficiency. But you can certainly have venous insufficiency without having varicose veins. And this is one of the things I see in my office all the time, which is easily missed by somebody who's not an expert, because if they don't see obvious, big, bulgy, ropey veins on the surface, they'll tell the patient, your veins are okay. But through ultrasound examination and so forth, we can prove that's not true.
And that's really the varicose vein part, right? Is the visible superficial vein that's had valvular failure that starts to distend and looks like a grape or a tortuous purple snake or whatever, but you can actually see them. That's kind of what most people think of when they think of a varicose vein, but you still could be having vein failure at a lower level that causes kind of more systemic problems that don't show up as a vein that you can touch or look at.
Right, and it can be, those visible veins go from everything that we call, they're known by lay people as spider veins or thread veins, but we call them telangiectasia in medical terms, and it's kind of a cool word, you know, like telomeres. Tele means at the end, angio means blood vessel, ectasia means dilated. So it's these dilated little ends of the veins that become visible on the surface, and they drive people crazy, especially women don't like to see spider veins on their leg. But sometimes they're purely cosmetic, but it can be a sign of chronic venous insufficiency. And then as the veins get bigger, we have something called reticular veins, which are larger blue veins that you can see coursing under the skin that look to be under pressure and not normal. And then finally, true varicose veins, which can be as big as my thumb or larger, that are really bulging, ropey, and you could actually sometimes see them right through somebody's pants.
Okay, so you have varicose veins. If you're watching, let's say you have varicose veins or you think you have venous insufficiency, and you're going to go see your doctor about it. What is your doctor going to look for on history when they're asking you questions and on physical examination? So someone like you, when someone comes in, what do you do on history? What do you do on physical examination typically in these situations?
One of the things, once we get to that targeted part of the history, you want to make sure that as physicians, we always want to make sure we're not missing something, right? Yes. So the big thing is there something that could be dangerous or harmful to the patient that I'm missing? So we want to make sure, for example, that the deep system of veins, because we're talking about superficial veins that are near the surface or just under the skin, but there's a deep system of veins too that lies within the muscles and near the bones, the femoral vein, popliteal vein, all of these things, iliac veins. We want to make sure that the patient, let's say, has never had surgery on those veins before, has never had a blood clot in those veins before, hasn't had a history of cancer that could put them at risk for blood clots in those veins, major trauma that could lead to scarring of those veins, things that we call post-thrombotic syndrome, which is a very important thing to understand. And so you would ask all of those questions, and that would be followed up later with a good functional venous ultrasound examination to look at the deep system as well. And then once you've ruled all of those things out and you're looking at the superficial system of veins and you feel comfortable that this is just varicose vein disease secondary to venous insufficiency, then a very thorough ultrasound exam in the hands of an experienced lab would be done to see where the problems are and what we could do to address them.
Okay. All right, so I've gone to the doctor. Yes, I have varicose veins. You've done your ultrasound examination. The deep system seems okay. It's more of the superficial system. What are my treatment options?
Well, it goes everything from conservative to interventional and surgical. Okay. And it depends a lot on the patient, and it depends a lot on the symptoms. Sometimes we see patients with absolutely rip-roaring, mind-boggling varicose veins that you can't believe your eyes, and they say, "No, they don't bother me at all."
I'm assuming the answer for them is then don't do anything.
Well, even in those patients, I would certainly suggest conservative measures like compression stockings. Why? Because they can still run into problems. We have had patients in my office that have walked around with varicose veins like that for 30 years, and one morning they wake up and the whole system is thrombosed, for example. So they have a rip-roaring, what we call phlebitis, thrombophlebitis, where this gigantic system of veins down the thigh into the leg and so forth is all clotted off now. It's red, it's hot, it's painful, and it is a difficult thing to deal with. It's not sort of like a thrombosed hemorrhoid that you can make a little surgery and fix that. That requires a lot of conservative TLC for a long time to get that patient through that. So that's why even with asymptomatic varicose veins, we would suggest a good graduated compression stocking. And one thing I want to point out to the docs is that always keep that in mind. Patients who present with phlebitis like that, good studies have been shown that maybe up to a third of those people will have a concomitant, meaning at the same time, deep vein thrombosis, a blood clot in the deep system. And the really fascinating thing about those studies is many times, equally, I should say, that DVT is in the opposite leg, in the opposite lower extremity, because you've set up that clotting cascade that's a systemic problem that we know so much about.
We do, and we worry about DVT as orthopedic surgeons. That's one of the risks, one of the complications of lower extremity surgery is development of a DVT. And the risk with a DVT is if a portion of the clot breaks off or something goes to your lung, now you have a pulmonary embolus, which is also a risk and a complication of some of the surgeries we do, and that can be fatal. So these are one of the things that keep us up at night.
And it's extremely common. I think, you can double check me on this, but I think in the United States about 900,000 DVTs a year in the United States, and maybe about 100,000 deaths from pulmonary embolism. So it's a really important subject.
And ironically, and this is another video, is we do not have a consensus really on how to prophylax someone after surgery, like whether we use a novel antithrombotic agent or an older one or aspirin or nothing. Yeah. That's a real controversy in our world. Sure. That's evolving over the last 20 years. Okay.
Yeah, so early on, so you have the asymptomatic or the minimally symptomatic varicose vein, compression stockings to reduce the progression, reduce symptoms related to that vein. What about basic other things like weight loss and exercise that are good general health measures? Would you say that they have a measurable effect on varicose veins?
I think it's important to do that always for overall wellness and health. Sure. But certainly we have lots of thin, fit people who come in with varicose veins because I think the most important factor is hereditary. Right. Heredity, quite frankly. We see it, I have in my practice 3 generations of people, grandparents, parents, and children. And in the children, you sometimes see them as early as 18, 19 years of age with significant, varicose veins and venous insufficiency. So, of course, movement, weight loss, good nutrition is essential. But when you have a genetic predisposition, it's hard to pick new parents.
Okay, so we talked about nutrition. We always talk with our patients on all the topics that we discuss. Are there any foods or supplements that have scientific evidence to show benefit for either the prevention or the treatment of varicose veins?
Yeah, it's a great question. Definitely, there's been 4 decades of research, especially on one complex called micronized purified flavonoid fraction. Okay. It's something that's near and dear to my heart. I was so impressed by the data that we saw on this. We've actually created a supplement called Vein Formula, okay, which is available in the States and coming to Canada in not too long. But that is a mixture of diosmin and what's called the hesperidin fraction. It's 5 bioflavonoids, and they have a profound antioxidant effect, and they increase venous contractility, what we call venous tone, decrease capillary permeability, and they actually have an effect even on the lymphatic function. And they're antioxidant and have been proven to be really valuable in supporting the venous system.
And so this is not a drug. These are plant extracts that have been put together in a supplement that has anti-inflammatory and antioxidant benefits for hemorrhoids as well. Same kind. It's a vein issue, hemorrhoids, varicose veins. It applies to both.
100%.
We'll put a link in the description if you want to learn more about that stuff.
Okay.
Okay, so we've talked about these compression stockings, lifestyle modifications, supplements, and now some interventions. Injections, laser. I've heard of injections, I've heard of laser, I've heard of stripping, I've heard of surgery. Can you break it down for us, kind of?
Yeah. Fortunately, again, I think all the docs on the show today are old enough to remember that historically the mainstay of this was what we called vein stripping. And vein stripping I did a lot of as a surgical resident. It was done here in the hospital. We're in the hospital here up in Toronto area, and it was done under general anesthesia, and it was quite quite brutal, quite frankly.
morbidity.
A lot of morbidity. In fact, many people did not get their varicose veins treated or their venous insufficiency treated because in many cases, the treatment was worse than the disease, which is never a good balance. We do no harm is, rule number one in the Hippocratic Oath. So it was really being reserved for the most severe cases, and then by reserving it for the most severe cases, you get a lot of morbidity. So it was kind of a vicious cycle. Fortunately, about 25 years ago, and I have to give our colleagues in Europe a lot of credit for this, they really paved the way for office-based, minimally invasive, what we call endovascular techniques. And one of the big advances at that time was what we call endovenous ablation. And it could be done with what we call a radiofrequency device or a laser. These are both just sources of heat. It's what we call thermal ablation. And basically, I like to think of it as heat shrinking the vein. You put a tiny little catheter inside of the vein, typically in the thigh area, and that's what we call a catheterization, venous catheterization. And we use that little catheter, little tube, it looks like a long cocktail straw, if you can imagine. And through that, we pass a little laser fiber, and we use that after numbing up the area with local anesthetic to basically cauterize the lining of that vein and heat shrink it and basically destroy the vein. So we don't have to remove it anymore. We shrink it, and then the body actually absorbs it. So after a few months, you bring the patient back for an ultrasound, it'll actually be completely gone. It's pretty amazing stuff.
And the blood that used to be in those veins just gets driven to the deeper systems. Is that kind of the thought?
Exactly. It gets rerouted automatically, instantaneously to the other systems. Right. And one of the questions that patients often ask, well, doc, if we do that, won't that put excessive pressure on the other veins? And the answer is that we know that the answer to that question is no. Now, the caveat to that is that doesn't mean that you've been cured. There is no cure for chronic venous insufficiency because it is a chronic progressive disease, like many diseases, like blood pressure, cholesterol, diabetes, etc. There's so many things. There are very few things like an appendix or a gallbladder where you have one, you take it out, you throw it in the garbage, and you're literally cured. So it is more like, I think of it more like dental disease, that if you have that predisposition, you need to see your dentist every 6 months to a year for an examination and for management. So we do manage venous insufficiency, and there's a whole spectrum of patients. There are patients that we kind of see as frequent flyers who might be in every 6 months for some management, and then there are people who go 10 years and never need another procedure.
And sclerotherapy, the injections, you do any of those?
Yeah. Sclerotherapy is a huge part of the contemporary management of venous insufficiency and varicose veins now. And basically, sclero means scarring, and therapy means treatment. So you're basically treating these blood vessels, these abnormal veins, by scarring them off. Thermal ablation uses heat to scar them off, and the sclerotherapy is an injection that uses a medication that basically causes a chemical burn or a medicinal burn to the lining of the vein. And one of the most common ones used now is actually a detergent, or a couple of different kinds of detergent, one called polydocanol, one called sodium tetradecyl sulfate, or STS. STS can also be used for hemorrhoids, by the way, Brad, you mentioned, for sclerotherapy injection. But you remember when you were a kid, you'd get soap or shampoo in your eyes and it'll burn your eyes, and that's why they had Johnson's baby shampoo. Well, soap and detergent is caustic stuff. So used in the right concentration, in the right hands and so forth, it can burn the vein. And one of the really fascinating things, I think you guys will find this interesting because you like these kinds of little tidbits. There was a doctor in France named Dr. Tessari, and Dr. Tessari was a vein specialist, and he was using detergent, liquid detergent, in the office to inject veins, smaller veins, because they found in those days that the bigger veins didn't close. It wasn't strong enough to close the bigger veins. One night he was at his home and finished up dinner and did the dishes. And after doing the dishes, he noticed all these soap suds in the sink that took a really, really long time to go down the drain. And he thought to himself, I wonder if I made the detergent in the office into suds, would it have more contact time with the lining of the vein and be effective? And lo and behold, that's exactly what he did, and it worked. And we call it the Tessari method. We agitate the soap between two syringes. Now they have companies creating these soap solutions. But a lot of times,
And his first patient said thank you, and bubbles came out of his mouth.
yeah, exactly. You'll hear it referred to as foam. That they call ultrasound-guided sclerotherapy with foam. But foam reminds me of some kind of like a foam material, like a mattress or a pillow. So I like to tell my patients it's soap suds. We're kind of washing away the bad.
Yeah, and your veins are clean inside like
Yeah,
never
exactly.
before. A funny story, when we did, when we did our general surgery rotations, part of our training, we used to do a lot of sclerotherapy. And I had a friend of mine came in, he had bad varicose veins, so we did sclerotherapy on one leg, and then he was going to come back and do the other one. Then my rotation ended. So he only got one done. And 20, 30 years later, every time I see him, and he says, you know what, this leg looks great, the other one looks terrible. Yeah. So it lasted like 20 or 30 years from that sclerotherapy. It really did work.
Why didn't you just go get the other side done?
I don't know.
He wanted Dr. Zalzal.
So I think I'm coming back on rotation
I'm coming back on
in 6
rotation.
months. And
There's
then
some
it
remedial.
got changed to neurosurgery, and I was like, do you have any headaches?
The other typical treatment today that we should mention is a microsurgical technique done in the office under local anesthesia, what we call microphlebectomy. It's different than a stripping. We numb up the area over the veins with lidocaine solution. It's done in the office, patient wide awake, doesn't require sedation. It's what we call ambulatory surgery. Patient can walk in, walk out by themselves. And we make tiny little mini incisions, 2 to 3 millimeters in size. And we have a little instrument called the vein hook, and we just pull those little veins out. It sounds like a big deal, but it's not. It works very, very well.
I love the technology. I just love the technology in varicose veins,
Yeah.
like lasers and stuff. We don't get to use a laser.
It's advanced tremendously. The one other thing that you guys touched on with your doctor friend as a resident that I do want to talk about is the progression of venous disease. Right. It's really important. It is not simply a cosmetic problem. Now, it can be a cosmetic problem, and certainly any patient with visible varicose veins after treatment gets a significant cosmetic improvement to their leg. But make no mistake about this. This is a real vascular disease. In the United States, there are 40 to 50 million people with venous insufficiency, and there are more days lost from work from venous disease than from peripheral arterial disease, if you can believe that. And as the stages progress, it goes from stage 1, which would just be spider veins, stage 2, varicose veins, stage 3, swelling in that lower extremity, which we now know as phlebolymphedema, where the lymphatic system's been overwhelmed. Stage 4, you would get discoloration, what we call hemosiderosis, especially in the gator area.
So the iron from your vessels gets deposited in your skin. That's why you see like reddish, brownish kind of permanent discoloration. You have like a tan of the lower half.
I call it like a biological tattoo that nobody wants. Yeah. And that, once you start getting those elements like iron seeping into the soft tissue, it sets up a very aggressive inflammatory response. And then we get something called lipodermatosclerosis, where the tissue starts to shrink and harden, become very tough. And finally, stage 6 disease is when you get an open ulcer, venous stasis ulcer.
And certainly we see this, and this is the reason we cancel hip and knee replacements for this, or you're trying to get someone ready and they're like, they have chronic wounds that are chronically open. We worry that gets infected, and then that goes to your bloodstream, and then that goes to your hip or knee replacement. So that certainly is very...
And that can be life-threatening.
100%.
Yeah, that's a big deal for us because this is one of the more common reasons where you'll have your surgery canceled if you have bad venous insufficiency and you have not even quite to the ulcer phase, just if it's really bad, because you are predisposed to getting a cellulitis when you have that poor circulation. Your body can't fight off infections as well, so you can get cellulitis, which is kind of like an infection in the soft tissues. And when we put big implants in people like hips and knees, we really can't have any bacteria swimming around in the bloodstream.
And we disrupt the system too.
Yeah, bacteria love to stick to our implants. So that's why when we apologize if we've had to cancel you for surgery, but that sometimes does happen as a result of venous insufficiency.
I want to mention, if it's okay, a couple of things related to that. One is if you do develop that ulcer, what we call a venous leg ulcer, VLU, or we used to call it venous stasis ulceration. Oftentimes it's right over what we call the medial malleolus, the inner ankle bone. And the problem with that is, even in patients who are significantly overweight, that's just skin and bone there.
Not a lot of meat there.
And when that gets exposed, you can also get something called osteomyelitis, where the infection gets into the bone. So you never ever want to be in that situation in your life because it's so difficult to treat. But the other thing that Dr. Zalzal just mentioned, which is so important and brings this whole circulation subject together, is that don't forget that the skin, I tell my patients, is not the largest organ in the body, it's the largest organ on the body. So it's the largest organ on the human body. It's covering us, and it's not just a pretty covering. It is an organ, and that's why there's a field of medicine called dermatology related just to that. And one of its huge functions is immune support, immune surveillance, and keeping us free of infection and so forth. So when the veins don't work properly and we get swelling in the limb, and that leads to inflammation and overwhelms the lymphatic system, which we've talked about in other videos, is not just circulation, but immune function. The immunity of the skin, that organ, gets compromised, and this is where those cellulitis, these kind of smoldering, low-level, chronic, non-healing infections in the skin happen, and that can lead to all kinds of problems. So it's all very much interrelated.
Wow. Okay. That's venous insufficiency, varicose veins in a nutshell. Anything to add?
I'd say take-home message for me is that you should start thinking about this early, like ideally even before you get it. So avoid prolonged sitting, which is an epidemic in our society.
Which we just did.
Right. Avoid prolonged standing, which is a big part of our job. If you can avoid prolonged standing, this is also good. You need to move. Exercise on a regular basis, and consider compression stockings maybe before you even get these problems. Eat a healthy diet, consider supplements if you have them, and if you have this problem, get seen and get assessed so that you can implement a multimodal treatment plan before it becomes a big, big problem.
When I said anything to add, I thought maybe like one sentence or something.
But in his defense, Dr. Weaning always does a great job pulling it all together. I love it.
He does.
Yeah.
Dr. Chuback, thank you so much.
He's like AI.
Yeah, BW. Thank you so much for hanging out with us and talking with us. And as you can tell, he's a very smart man. Check out his links in our description. Sure. He's got podcasts, he's got YouTube channels, he's got books, he's got a company, lots of interesting stuff. We really appreciate you coming and hanging out with us.
It's been my pleasure. Thanks for the invitation.
Remember, if you like it, please like it, subscribe to our channel.
And remember, you are in charge of your own health.
We'll see you next time.